I'd like to talk about something today that I really thought a lot about over most of my career, in fact, and I've changed the management over the years, and I wanted to sort of share with you some of the pitfalls of what I used to do and the reason why I've evolved into the current way that we treat them. This is where I'm from. This is the foothills of the Rockies, where the University of Utah sits, and we're blessed with some of the most dramatic parks in America in the southern part of the state, northern Arizona. So I'll show you this case as an example of the problem that I see in skull-base surgery. This is a patient that's been blind for 2 years. She lives in Montana. She's never sought medical care. And she came down to us because she was an extremist and she was starting to herniate here. And we removed this tumor, at least the part that was compressing the temporal lobe, to save her life, and it was adenoid cystic carcinoma. And of course, we don't have any level 1 or 2 evidence on how to treat adenoid cystic carcinoma. And most of these skull-base tumors, we have to rely on the experience of people to tell us, and we make sort of iterative improvements in the management based on that paradigm. So I will say that skull-base surgeons must be familiar with the orbit, and this is something that I've learned over the last probably decade or two. And when I trained, we spent a lot of time working on the cavernous sinus, and these are all Al Roten's beautiful dissections that he left to the world on the website, and you can free to use them. And basically our knowledge stopped here at the region of the anterior clinoid. And it was ironic, actually, because I think the cavernous sinus is much more complicated than the orbit is, and it's something that we can master. There's a beautiful lecture by Al Roten on the anatomy of the orbit, and I encourage you to look at this. Obviously, there's 7 bones that contribute to the orbit itself. All of them you're familiar with, except probably the palatine and the lacrimal bone. But it's easy to learn, and I would invite you to think about the factors. And we heard a lot of talks earlier today, supraorbital approach, lateral orbitotomy, etc. But with the anatomy in the orbit's what's important. So for those skull-base surgeons, we use a landmark. I use a landmark personally of 4 crossing 3 at the superior orbital fissure. It's an important landmark. Notice the 4th nerve goes outside the annulus is in. The 6th nerve and the 3rd nerve goes through the annulus is in. And so this is the 5th nerve lying on top of the levator here. And the 6th nerve is the only nerve that stays lateral. Every other nerve goes medial. And this is a trend that you see with the arteries and the veins in the orbit. The superior orbital fissure starts lateral and goes medial, or the superior ophthalmic vein, I'm sorry, and the ophthalmic artery also starts lateral and goes medial. But when you take away the fat, you realize that there's not a lot of anatomy. It's fairly easy to predict, and the fat is your buffer. It's actually a very forgiving structure to operate on. And I'm going to show you, because a lot of the disease that we deal with in the intracranial space obviously involves the orbit, and this is in our wheelhouse, and we should be able to take care of it. We've written a review, and there's 2 ways to think about these approaches. One is to approach disease within the orbit, and then as Sebastian introduced to you, you can use the orbit as a corridor to the other aspects of the intracranial space, middle fossa and frontal fossa in particular. This is a list. I like to simplify things, and when I think of disease in the superior and lateral part of the orbit, we use either a lateral orbitotomy or a transcranial, transfrontal approach to the orbit. And if the disease is, and this is a list of the disease from that paper, a lot of it is neurosurgical disease. If the disease is inferior or medial, we use an endoscopic approach. This can be done transnasally or transethmoidally. But let's talk. So you've got a case like here. Here's a V1 schwannoma. It's on top of the optic nerve, so we'll do a transfrontal orbitotomy on this to come from above, so we don't have to manipulate the optic nerve. And if you've got a tumor like this is a meningioma of the medial inferior part of the orbit. This is beautifully addressed with an endonasal approach, and you can take down the medial maxillary wall, and then you've got a beautiful corridor to the inferior part of this tumor. But let's talk about spheno-orbital meningiomas. In my mind, this is the epitome of the problem that we face with these tumors. Middle fossa tumor, removed in the community, and the doctor said everything's fine, the tumor's out. But yet the eye is proptotic, and they're uncomfortable, and and the pressure in the eye is a problem, and exposure keratitis when it gets bad. And the reason is that the bone is involved, and the bone was never removed. And the hyperostotic bone is tumor, and so we try to remove that. So here's a dramatic case, and this shows you the sort of classic appearance of a spheno-orbital meningioma, how it grows. So it starts in the lateral sphenoid bone. Here you've got extracranial tumor, you've got middle fossa tumor, and you've got tumor in the orbit. You can measure the proptosis and compare it to the non-involved eye. You get a proptosis index, and that's our guide to how much the eye is exposed. This is a very dramatic case, and she came in, she's from Eastern Europe, and nobody ever offered her treatment. And when I started doing these surgeries many years ago, I was unhappy because I would remove the tumor, and I thought I was being aggressive, and I would drill the bone, and the eye still would not reduce, and I'd follow them up, and I was frustrated. And so I progressively over the years became more aggressive with dealing with this disease. And then I published this paper several years ago now on a smaller number of patients. But what we've done is we've gone to this approach now. Now, ironically and luckily, the orbital rim is not usually involved with this disease. It's the lateral sphenoid ridge. And usually the orbital rim you don't need to mess with, so that's your guide. And we remove all the tumor that's involving the bone, superior and the roof of the orbit and the lateral part of the orbit. So this is what it looks like. We do a frontotemporal opening, and we're able to remove the roof and the lateral orbital wall, right down to the inferior orbital fissure, and then obviously remove the clinoid and decompress the optic nerve. So here's a case in point. Here's somebody, the same case as I showed you earlier, on the left side, that had a middle fossa meningioma. It's in the sphenoid bone. He's terribly uncomfortable with a tense and painful eye. And what we'll do in this case is we'll look at the CAT scan and notice where the thickened bone is. And it goes right back to the carotid artery here in the petrosal bone in the canal. And we'll remove all of that bone. So we'll remove all the involved bone because it's a nidus for recurrence, and it's obviously causing terrible proptosis. So I'm going to show you a video of this woman from Europe with a terrible proptosis. And as I said, she came in extremis because she had temporal lobe edema, and here you can see her medial temporal horn, and it's almost to midline. Here's the tumor. So she's got a soft tissue component, but a lot of it's bone. And so what we'll do is we'll do a frontotemporal approach and then drill out the involved bone. Now the bone's very thick in these cases. It's like operating on a fibrous dysplasia patient. The bone can be several centimeters thick. She's got tumor extracranial here, and we'll go ahead and drill out all the abnormal bone. So what we do is we just keep drilling out the bone until we're into normal bone. We'll leave the rim intact, as I mentioned. You can see it's very vascular. And then we'll go ahead and, just like you're all familiar, we'll remove the tumor in the middle fossa, in the frontal fossa. But here I've now drilled the orbit, and you can see all the periorbit is involved with tumor. Here's the lateral orbit, superior orbital fissure. Here's the optic nerve and a giant clinoid. And so we'll go ahead and spend the time and drill out the clinoid and remove that, so we decompress the optic nerve. And then I'm going to show you what we do with the orbit, because this is the key to this approach, and this is what I've learned over the years. So we'll drill all the involved bone, and then we'll start the orbital dissection. So here we're removing the middle fossa tumor, and that's all straightforward. But we start right behind the orbital rim and open up the periorbita, and then find the plane between the periorbita involved tumor and the fat. Remember, the fat's your buffer. It's going to protect the nerves. It's going to protect also the muscles. So just stay right on that plane and dissect it all the way back, and you'll take this right back to the region of the annulus of Zinn. Now, if the annulus of Zinn is involved, we don't take that because this is where the muscle's attached, the cone muscle's attached. And so, but in a lot of the cases, it's not. And so we're able to remove it. We use retractors to hold the fat back. It's a perfect indication for that. And then we'll go ahead and close the dura. And you'll see all I do here in this particular case is we'll put in some fat adjacent to the orbit and not reconstruct it. Because when I reconstructed the orbit, it impeded the improvement and reduction of the proptosis. So we got into the frontal sinus, we got into the ethmoid sinus in this case. We'll go ahead and plug those off with some muscle plugs. and some fibrin glue and divert CSF. Now this is what it looks like post-op. See how much she's reduced. Look at her optic nerve, it's almost like a road course now. So she's had great reduction of her proptosis, and you'll say she's going to get enophthalmos. And I'm going to make a case that that's not necessarily going to happen in these cases. So she came back for a custom implant because we had removed so much bone. So we got a 3D custom implant made for this case. And when we put it in, you'll see the reduction in the proptosis that she's had. This is 2 weeks after surgery. So here you see, this is pre-op and this is 2 weeks post-op. So she's had a dramatic reduction, and I followed her now for several years, and she's done fine. So we originally published a series of patients with 38 patients with bad proptosis, terrible proptosis. And we wanted to see how much improvement we could get in the proptosis and whether we were inducing enophthalmos in some of these people. About half of them went on to radiation. This is an interesting case. I had never seen this before, but this is a primarily hyperostotic tumor. We drilled it out. You can see all the bone that's been drilled, just like I showed you. And then 7 years later recurred, but he didn't recur with soft tissue, he recurred with hyperostotic bone. So this is a very interesting phenomenon. I don't know why this occurs, but it's quite interesting. So the real issue here of variability in treatment is the idea of what you do inside the orbit, okay? And this is where the ophthalmologists sometimes weigh in. Most neurosurgeons, it's a sort of an orphan zone between the orbit and the cranial space, and so they stop. And I'm going to make a case to you that we should continue on and be aggressive. I'm going to show you some cases. So this is proptosis index. Note that none of these patients developed enophthalmos. So this is a different disease. They've got a lot of fibrous tissue around when they heal, and they don't overcorrect. There's other reasons for proptosis as well. This is an interesting case. I'll just show you the CT on the patient, the MR, but you can see it's frontal sinus enlargement. And this is pneumosinus dilatans, and Ann Osborne taught me about this. It's when you have a meningioma growing next to a nasal sinus, it blisters the sinus and creates mass. And a lot of the mass here was from the sinus, so you have to drill that out if you're going to decompress the orbit properly. So we remove all the bone and soft tissue, as I showed you. We remove intraconal tumor if not attached to the muscles, and in younger patients, we'll remove the muscle because they already have diplopia. The ophthalmologist can straighten the eye out, and we do it for tumor control. We've written several papers on this, but I'm going to show you the most recent results on a series of 89 patients where I've done this aggressive surgery on. We have a big series of way over 100 patients, but these are the ones that I did the aggressive resection on over the last 15 years. And I want to call out Farshad Nasiri, who's a fellow of ours from Toronto, and he helped put this together. So we've graded this amount of involvement in the orbit, and I just wanted to share what my thoughts are about this. So grade 1 tumor is sphenoid wing tumor in the bone, plus tumor, soft tissue tumor in the middle of the anterior cranial fossa. Grade 2 is when the periorbit is involved, and that should be removable easily. And that's resectable. Those two are resectable. Grade 3 is where it gets more questionable. So you've got intraorbital involvement past the periorbita without muscle invasion, and most of the time you're able to remove this. And with muscle invasion, you'll have to make a decision. So you either remove it or you leave it and then treat it accordingly with radiation. And then grade 4 is, in my mind, is a tumor that defies surgical removal of complete surgical removal, and that's orbital apex involvement or optic nerve involvement. So diagrammatically, this is how it looks. You've got thickening of the bone. You may have a middle fossa tumor here in grade 1. In grade 2, you've got involvement of the periorbita. In grade 3, you've got involvement of the muscle, at least the lateral rectus, maybe the superior rectus and levator as well. And then grade 4 is when the orbital apex or optic nerve is involved. So here's a grade 1 tumor, and you can see the periorbit is intact here. On the other side, in fact, the medial cortex of the orbit is intact. And in this particular case, we'll just go ahead and remove that, and they have a good result, and we'll decompress the orbit where the bone is pushed in. Grade 2, here you can see very carefully, and we had a radiologist that did this study with us, and they're pretty good at predicting whether the muscle is going to be invaded or not. So this, you can't always tell, but we would predict that this muscle would not be invaded. So we would just go ahead and try to remove this tumor properly. And in grade 3, it's much more difficult. And here you've got a tumor now that's involving the bone, it's involving the periorbita, it's in the orbit. I can't see the lateral rectus at all. And obviously there's tumor here, extracranial as well. So I want to make the case that it's worthwhile to take a look at these patients and to explore it, because you never know what you can achieve. And I've been very surprised that we've been able to achieve more than we thought we would preoperatively. So here's this tumor. It's eroded the bone. It's in the orbit. The question is it involving the muscle? So we'll go ahead and take a look. So frontotemporal approach, left side, and we're resecting interorbital tumor. And so what you want to do, and the way I like to do this, is debulk it, get rid of the middle fossa tumor, and then find normal periorbita. That's the key. And so what we'll do is we'll go ahead and we're pulling down, we're going to decompress the optic nerve. So needless to say, in all these cases, we drill out the optic canal and then we remove the clinoid. So here's the optic nerve and open up the falciform ligament. You see here the anterior clinoid is all involved with tumor. Open the falciform ligament so you don't get any constriction, and then make sure that there's no tumor in the canal underneath the falciform ligament. So you can see here the ophthalmic artery, the optic nerve. So after that's done, we'll go ahead and concentrate on the orbit proper. And so I like to drill the bone and find normal periorbita. And then you find the margin between where the tumor is involving the periorbita. And you'll see, after we spend some time, open up the periorbita and strip the periorbita, this orbit is not invaded and the muscles are not invaded. So you can achieve a great decompression and do a great removal and offer the patient some symptomatic relief. So this is tumor down in the pterygopalatine fossa. We're chasing out, that's V2 right there. And here now the orbit's completely decompressed. Okay? So we'll go ahead, we got into the sphenoid, so we'll plug that. And I'm going to show you the post-op scan on this because I think it's very interesting. You see we've decompressed the orbit, the proptosis is better, and we could not see any true tumor that we left in the orbit. So sometimes you can do a better job than you think you can based on the preoperative image. So these are the demographics of the patients that we had long-term follow-up on. And about half of them present with visual problems, a half with proptosis and diplopia, a quarter with diplopia. And the bottom line is, on the grade 4s, we didn't obviously attempt to do complete removal, but we were able to improve their symptoms and improve their proptosis in those cases where they had significant proptosis. So I just want to leave in the last couple of minutes a footnote and have people think about this, because I've given this a lot of thought over the years and I've seen so many patients with failed meningioma treatment, and I think this is a very common area to be done where they failed treatment. So here's a grade 1 spheno-orbital tumor, just as I described to you. She's a woman that she was 41 at the time, progressive proptosis. This was a middle fossa tumor. The bone was not drilled. And you can see there's mass now. So now she's several years later, she's had orbital surgery, every time a partial removal for 3 times, and then they go ahead and rate it. Now she's got a grade 3 tumor and probably grade 4, and it's also marching back to the cavernous sinus, you can see there. And here now in 2019, she's lost her vision, she's got a non-functional eye, the right cavernous sinus is involved, and the left is in jeopardy. So it's approaching the left. So this then requires a salvage surgery. She's had radiation. And I will tell you that the orbit, we can go ahead and remove all the orbit without any problem. That's a prosthesis that was put in by the eye doctors, and we'll just take that out. And we'll do a removal of all the tumor in the orbit, the cavernous sinus, and in the face. And this requires a big, dangerous operation. And I think in a lot of cases, we may have actually avoided it if we had been aggressive initially with these tumors, because it's a common place for them to recur. So there's the orbit. Remember, the blood supply to the orbit comes through the ophthalmic artery, so if you control that, that's fine. This I just wanted to point out because when these recur, they parasitize blood vessels, and so what you'll see here is I'm dissecting the middle cerebral off of the recurrent tumor, and it's parasitized the middle cerebral. And so this can be very dangerous. So you really want to be careful and just cauterize the vessels that are feeding the tumor only. And so we'll go ahead and remove that. We're going to do a cavernous sinus resection here and tie off the carotid. And then she already had a balloon occlusion test. We don't need to bypass this patient, but we'll do an aggressive resection, and we'll tie off the carotid, cut the optic nerve, and tie off the carotid in the neck, and then go ahead and resect this. So it's an all-day venture, and then our ENT colleagues helped put a free flap in to close. And I think I can show you the post-op scan here. So we'll put an EVD in these patients. That's a thigh muscle flap in there. And we were able to give her several more years of life, but not without a lot of risk and a lot of ICU time. The other thing that we're facing is we're facing a wave now, a tidal wave, of all these long-term survivors from radiation therapy when they're children. And the radiation therapists, as you know, don't usually follow patients, and so we're seeing all the complications of that. But this is the kind of case that we see quite frequently now, where you've got a spheno-orbital tumor. Look at this tumor down in the throat. This woman couldn't even breathe. It's terrible. So we did multiple surgeries on her. So, and I don't have time to show that, but I want to thank you very much, and I think we got to take more responsibility for the natural history of the disease, so we should be more aggressive up front. And I realize that nobody wants to hurt the patient. What happens is the ophthalmologists do Whittle surgery, and then the neurosurgeons stop at the orbit. So I think we're not offering the best treatment for this particular disease. If it's surgically resectable, we'd like to remove it instead of radiate if we can avoid. And I want to thank you very much.